Okay.
Yeah, that's fine.
All right. So today it's a privilege to have Dr. John Morley. He is a professor of internal medicine in the Division of Geriatric Medicine at St. Louis University School of Medicine. He is, he has edited more than 20 books and published more than 1,400 papers with major research emphasis on the role of neuropeptides in the modulation of hormonal responses and behavior. Clinically, he focuses on diabetes, nutrition, frailty, sarcopenia, cachexia, I hope I did that right, and cognitive assessment. So it's a pleasure to have you, Dr. Morley.
Deborah, it's great to be back talking to the students at Kirksville. It's always a lot of fun talking to you guys being both men and women. So in case you think I'm trying to be sexist there, but in my mind, it's a single non-gender term. So what I'm going to do today is talk a little bit about COVID-19 in general and some of the things associated with it, particularly in older people, and then spend the last half of the talk talking about the long-haul COVID syndrome. So as I think we all know, COVID came from Wuhan in China and then basically spread both first to Northern California, which I think very few people actually realize that this was the A strain. And it started there and then moved up eventually to Washington. And it actually started spreading in early February in Northern California. There were 3 or 4 cases that were identified. At the same time, the siege strain actually went to Italy in Rome and Milan in particular. And they had a much worse time than the people on the West Coast had. So as you know, basically, we're in the middle of a pandemic. There are slight ethnic differences in the outcomes, with basically people of dark skin, particularly African Americans, having a worse outcome on the whole than people who have a white skin. But that may be more socioeconomic, related to where you live and how much you live on top of other people. So people who have lots of people living in their area tend to have the disease spread quicker and also have worse outcomes. So when we look at this pandemic, the people who do worse besides the ethnic places are old people. So the older you are, the worse you're going to do. If you've got visceral obesity, high blood pressure, diabetes, if you're a smoker, you have poor outcomes. And then there's some data suggesting that if you are frail in older people, and this has usually been done using the Canadian Ken Rockwood picture of frail people, which is not an ideal way, I don't think, to look at frailty. But realistically, in the studies that have been done, it's shown that people who come up as frail, and the problem is that the lower pieces of his frail are very disabled people. So it's not the same as the physical frailty that I like to deal with. So common in frail people, common in older people. There are a number of COVID variants, as you all by now have to know, unless you never watch TV, never listen to the radio, never read anything. The first variants that became popular or well known was the Kent variant in the UK, the Alpha variant. We're now down to the Mu variant. The Delta variant, which came out of India, has most probably been the worst of the ones so far, but there's now a new Mu one and also the Lambda variant out of Chile. So a number of different variants. Each of the variants have slightly different effectiveness, and some of them, like the Delta, seem to spread much more quickly than some of the other variants. So when we look at COVID-19, it's spread around the world, and depending where you are in the world, and depending on, I shouldn't say this, but depending on whether your politicians are total idiots or really highly functional. So I go to Singapore a lot. The politicians there are extraordinarily functional, and you will see that there are 7 deaths per million in the population. And my wife wanted us to go live in New Zealand when we were coming from South Africa instead of here. And you can see there that the politicians do very well. And in Taiwan, they do extraordinarily well. And having been to all 3 countries, they are very well-regulated countries. And I think that's the first thing we have to realize, is that a lot of what we're seeing has to do with the ability of politicians to regulate the social activity of people. The countries that have had the most deaths per million are Brazil, Argentina, Colombia, Italy, and then the UK and USA are about the same, and then Mexico and Spain a little bit lower. And as I've told you before, and basically COVID deaths increase dramatically the older you get. So somewhere around about 65 and beyond, it becomes a very major disease. So there are lots of vaccines around. You're seeing here the Pfizer, the Moderna, the Johnson & Johnson, the AstraZeneca and the Novavax, but there are 2 vaccines from China, and the Sputnik vaccine from Russia are also being used around the world. Most of them are approved for people over 18, or the Pfizer is now over 12. They are very effective at stopping people dying, and they all seem to work against all of the variants, which is important. And in preventing any disease, the Pfizer and Moderna are around 95%. Novavax is also around 95%. The others are in the 70%, but very high at preventing serious disease. They all are basically functioning on emergency authorization. The viruses are either messenger RNA, a viral vector, or recombinant protein adjuvants. They have, for those of you who haven't had, and I'm assuming all of you have been vaccinated, that basically they have a little bit of side effects when you get them. You tend to feel fatigued. My Pfizer vaccine, I was fine the first one. The second one, I felt pretty terrible. And my wife felt really terrible with the second one. She got Moderna, I got Pfizer. These drugs are being tested now in younger children. And basically, if you don't have an allergic reaction to the substances in the vaccine, it seems to be a relatively safe vaccine. When we want to look at who's got vaccinated around the world, and this was September the 21st that I found data for, highest vaccine rates are in the United Arab Republics and Portugal and Iceland, Malta, Qatar, Spain, Singapore, Seychelles, Uruguay, Chile. And if you go all the way down, about half of the way down here is Israel. I bring that up because we keep on hearing that Israel needs the booster because basically they're having breakthrough infections. But they, in fact, when they were doing this, were at about 50% vaccination. And you expect to see, when there are a lot of people getting it, for much higher breakthroughs. So the breakthrough vaccine, which was approved for older people and virtually also by CMS for clinicians and virtually everybody, if there's absolutely nothing wrong with you, it wasn't approved for you. And that all happened yesterday with some arguments amongst the experts about whether it should be approved. And if we work our way down, you can see that about 63% of Americans in the United States have had one vaccine, and somewhere around 50% have had both vaccines. So we're way behind in vaccinations in the United States, which is part of the problem we're having. And we'll talk about this. So this is just showing you Missouri, which is where we all live at the moment, and pointing out that depending where you live in Missouri, you've got a chance of having over 50% vaccination or not. So if you're in Adair County, which I think is somewhere near where Cokesville is, that's about a 38% are vaccinated. If you go down to Perry County in the south, it's 34%. If you look in the middle with Columbia, basically it's somewhere around 51% in Boone County. DeKalb is 30%. That's the lowest of the bigger cities. Greene and with Springfield is 42%. Kansas City is 43 to 50 something. It's in multiple counties, as you know, and so the numbers are different. And then St. Louis is 46. Our county is 51%, and St. Charles is 51% as well. So we have not done overwhelmingly well at getting people in Missouri vaccinated, and we'll talk a little bit about that. As I think you all know, when I first put this slide together, 1/3 of Americans said they won't get vaccinated against the coronavirus, despite hearing that it would be with us for years if we didn't get it, and it might well kill you. This was the anti-vaxxer group. The data has changed a little bit, and I'll show you some of that just now. A newer survey went down to 37%, said they had no plans to get vaccinated against coronavirus. Americans aged 18 to 24 were the least likely to get vaccinated, with only nearly 60% saying they didn't want to get vaccinated. And men were more likely than women to say they'd get the shot, and Democrats were more likely than Republicans, though there are some differences there, and we'll talk a little bit about that in a minute. Nearly 50% of participants said they would respect the choice of people who chose not to be inoculated. Given that anyone who chooses not to be inoculated is actually trying to kill you, it's amazing that 50% of Americans think it's quite okay for people to kill you. But as I really care about population health, I'll point out that our gun laws have nothing to do with population health either, and Americans are really stupid when it comes to population health. I apologize to those of you who think I'm talking to you. So different people have different reasons for not getting vaccinated. The vaccines are too new or were rushed to market too fast. There are concerns about side effects or safety, distrust in the government or medicine, especially from people of color. And the Tuskegee experiment, which you all know about, really still hangs over a large number of the African Americans who feel that they really can't trust things that the government comes out with. And we've got to recognize that they and rural Americans are the two groups who are least likely to get vaccinated. There are many who feel that the medical system has betrayed their trust in other ways. They question the benefit of vaccine based on breakthrough infections, which typically don't make you very ill or kill you. Or they wonder whether or not their own immune system is much better than having a virus. And that's not the case, by the way, but people like to believe it. More than 1 out of 10 people surveyed said the main reason they had not got vaccinated was one of the following: too busy or lack of time, difficulty traveling to a vaccine site, concerns about missing work, and then don't like getting shots. So the last one I understand. I don't like getting shots either, but it's a bad reason. The other three, if you work in rural areas and you find a way to get the vaccine to people, that will markedly increase about 5 to 10% of the people who will get vaccinated. In the July vaccine monitoring poll, only 14% of respondents said they would never be vaccinated for COVID-19. Another 3% said they'd only get the vaccine if required, presumably if their employer told them they had to, or there was a mandate, they couldn't work. And in fact, quite honestly, one of the things that works very well is if you tell people that they're not going to be able to keep their job, and that does make them get vaccinated. So it's most probably for the people out there who haven't been vaccinated, the single best way to get them vaccinated. So let's now look at what happens to you if you happen to not get vaccinated and you get infected with COVID, and you're going to get, first of all, a cough, sore throat, dyspnea, chills, and hypoxia. You're not necessarily going to get a high fever, so that's something to be aware of. You may get liver disease. A number of people will get myocarditis and have myocardial infarction. Chilblains are fairly common because you basically get small clots around the body, and both peripheral vascular disease and deep vein thrombosis are not rare. Kidney injury can occur. A lot of muscle pain is fairly common, and if you have severe cytokine excess, you're going to get muscle wasting with cachexia. Otherwise, you're going to get some degree of sarcopenia. You may get some GI upsets like colitis and diarrhea. If you're a type 2 diabetic, you may turn into a type 1 diabetic in a small number of cases who get COVID related to the cytokines damaging the insulin release. Almost everybody with COVID gets anosmia and a decrease in taste. They can also get anorexia, and then they get encephalitis, headache, fall, and stroke. Multiple abnormal labs occur, and a big one, of course, is lowering your protein levels, your albumin level. So how do we make the diagnosis of COVID? By now, I guess almost every layperson in the country knows you can basically do it with a PCR, polymerase chain reaction. They're about 97% accurate. They are not necessarily positive in the first couple of days that you're infected, and they detect those who are infected. The antigen test is a lateral flow test that uses monoclonal antibodies to detect the virus's nuclear capsid protein, and you can also use CRISPR to do the measurements for this. Antibodies, they come a little later. The IgG antibody stays up longer than the IgM, and they detect those who have had disease. So we need to recognize that. So when we come to treating people, this week's British Medical Journal has a beautiful sort of graphic showing what is useful, what isn't useful, and why it isn't. And it's slightly different from things that I have read, but they make the point basically that if you want to do better, obviously, the thing that seems to work best at this moment in time is antibodies. You have to realize that convalescent serum does not seem to work very well, and therefore it's not a choice. But as I'm sure all of you have heard on the news, the whole of the south of the United States and Idaho have been using up all the antibodies because they didn't want to get vaccinated, but they're quite happy to take an antibody. I will point out to you that antibodies have a higher rate of side effects than vaccines. There are other drugs that are under development, but the antifungal one, the ivermectin, works for horses if they've got a parasite, but for human beings, they don't work, but it seems to be very popular, and a lot of doctors seem to think it's reasonable to give this to people, even though it doesn't work. I'm sure you all have worked out that hydroxychloroquine doesn't work now, and that was a political thing, that there was one paper which was very poorly done that said it would work, and this was put out by politicians as something to do. Remdesivir, according to the BMJ, is hardly worth taking, and their reasoning is fairly straightforward. It is that if you basically don't take it very early, it has very little effect. So you've got to take it almost before you get the disease. And it's a little bit like tamsulosin for flu, a small effect, but not a big effect. Besides the antibodies, people are trying to develop antisenses to work against it, and these most probably will eventually, but there are none on the market at the moment. And then people who are really sick need anticoagulants because of the increase in basically clotting disorders. In nursing homes, we have to recognize that when you put a group of old people who most of whom have some degree of immune function, together. It's going to spread like mad. The one that shows us best is the Spanish Army found a care nursing home in Spain where virtually everybody had been dead or abandoned. You have to recognize that we need personal protective equipment, particularly in places like nursing homes. And at times that there's been a real shortage of it. You have to, in nursing homes, test both the staff and patients regularly. And if you're going to let visitors in, they need to be tested when they come in as well. But the personal protective equipment is absolutely essential. And it's also important if you work in a nursing home, not to trust hospitals, not to send you untested patients. In one of our big nursing homes, they got a large number of people with COVID, all traceable back to the hospitals, sending them back to them, more or less knowing that they most probably had COVID. And obviously, isolation has to be done. We'll talk more about that in nursing homes. People in nursing homes, most persons in nursing homes are positive, but their symptoms are not overwhelmingly obvious, and that's something to watch out for. So the atypical symptoms are often missed. We realize that nursing homes have high touch care. It's hard to isolate demented people in nursing homes. Caregivers are not good at getting themselves vaccinated. In Missouri, we're under 50% vaccinated amongst caregivers and nursing homes, and that's just not enough to be protective. There are multiple reasons. We've talked about some of those reasons. It's very, very hard to get people who are on the lower side of the socioeconomic group to feel comfortable about taking the vaccine. And then nursing homes have low resources, and basically you've got to watch out. You've got to keep people somewhat separated, and we'll talk about the problems with that later. So one of the things you have to realize is most people with COVID fundamentally finish up getting themselves into an ICU, or they've developed delirium and they perform poorly. And as the cartoon here says, the restraints are for your own protection, Mr. Norris. We're concerned that if you keep ringing the nursing station once more, they'll strangle you. And that's about why most people get tied down in hospitals. I feel incredibly strongly that this is an inappropriate behavior. It's equivalent to torture. And quite honestly, we still do far too much of this throughout the United States. If you do it in England, you'll finish up losing your license. If you're a nurse who does it, you will also lose your job. So you have to recognize that some parts of the world don't find it necessary to tie people down. There are many ways to treat delirium. One is looking for the causes and treating them. Two is just to calm people down, and it works very well, and you really don't need to tie people down. Tying people down basically leaves them in the end with a post-trauma syndrome. So you finish up having people with multiple bad dreams, bad outcomes after they've been tied down. So if you basically treat delirium properly, you fundamentally will find that you will have virtually no problems and they will do well. If you don't treat them properly, you're going to finish up finding that basically they're going to have PTSD, anxiety, depression, cognitive impairment. It's a vicious cycle where you add restraints to sick people, whether they're in the ICU or not. When I worked in South Africa, we never tied anybody down in the ICU. And I was shocked when I came to the United States to find that where you had 4 to 5 times as many staff in the ICU, somehow seemed that the staff tied people down so they could have their breaks and not be near people. So I feel, as you might guess, this is something I feel very, very strongly about. And I have been told by nurses that I don't know what I'm doing, but I started my life out as a nurse's aide, and I think I do know what I'm doing. So this is basically, when you look at ICUs, 59% use physical restraints in the ICU, 58% use in the adult ICU over the age of 65, which is torturous. 51% use them in ventilated ICU patients. This makes no sense. Ventilated ICU patients are sedated. If you're sedated, you can't jump out of bed. 53% of nurses believe restraints reduce falls, and all the data shows that's not true. When I first came to Missouri, I went to a nursing home where 55% of people were restrained. We got rid of the restraints and we reduced the falls by half, and 45% report the risk of complications from restraints is low. And I hope I've just pointed out to you that these restraints are high. So besides the restraint problems, ICUs are not nice places to go in. And post-ICU syndrome is very common. This is what children of aging parents need to know. And it's not good. Patients surviving severe SARS-CoV infection and their relatives have an increased risk of developing post-ICU syndrome symptoms in all domains it encompasses, and these include muscle weakness, fatigue, difficulty swallowing, cloudy thinking, difficulty concentrating, poor memory, difficulty sleeping, sadness, and anxiety. So when we look at the post-intensive care syndrome, basically, we have to recognize that it produces psychological impairments, anxiety, depression, sleep disorders, cognitive impairment, memory difficulties, concentration difficulties, slowed mental processing, physical impairment, weakness and balance problems, neuromuscular impairment, and breathing problems. Should point out that about 20 to 30% of people over 60 who go into an ICU and are ventilated at 5 years later have not recovered their full strength, which is a major problem if you want to look at it from that point of view. And then, of course, once you've been through the ICU, you need trauma-informed care because the trauma syndrome is a very common one. So just before we go on to long COVIDs, I would like to quickly point out that you have to isolate people as much as possible, and you need good air conditioning. That little diagram at the top shows that people who went to the restaurant, the people next door to them also got COVID when somebody in the middle room had COVID. So watch out for that. And the concept is that you should keep about 6 feet apart. Basically, being isolated is hard, particularly in people in assisted living facilities. Lockdown is not good, as this lady says. It's kind of the same routine. It does kind of get boring once in a while when people are doing this. The other thing to recognize is that when you start to isolate people, you increase the loneliness epidemic that we see in older people. As Ernest Hemingway said when he got older, no one should be alone, but it is unavoidable. And our Surgeon General said during my years caring for patients, the most common pathology I saw was not heart disease or diabetes, it was loneliness. Basically, recognize loneliness leads to stress, depression, poor quality of life, poor sleep, worsening mentation, impaired function, cardiovascular disease, increased hospitalization, and increased mortality. We have developed an alone questionnaire to pick up people who are lonely. It's very quick to do, unlike the UCLA one, which takes much longer. And you can see that the ROC curve is very similar. What do you do for people who are lonely? You put them into a circle of friends where you encourage them and use an encouraging intervention for alleviating loneliness. This has been well shown in Finland. We have done it here, and it is an excellent way to look after people. We also need to recognize that COVID has been referred to as the boomer remover. In Italy, where 23% of the population is 65 or older, some of the hospitals used chronological age-based cutoff to ration ventilators. This is distributive justice, and that is never good. Many healthy young adults initially ignored the recommendations to socially isolate and protect their older relatives. This is respectful ageism. And then the Texas governor suggested that older people, including himself, would volunteer to die so Americans don't lose our whole country. And that is benevolent justice, but benevolent only for the people who think that's a good thing to do. Realize that old people, whether you're talking about the Dalai Lama, whether you're talking about our previous or present president, whether you're talking about the Pope or Queen Elizabeth, are all very functional people. And we should not make the decision that because somebody's old, they're not playing a functional role in our community. Remember that people who die from COVID, basically their family report severe symptoms for themselves or traumatic stress, helplessness, horror, anxiety, sadness, anger, regret, and basically guilt. All of these are being magnified because they can't be with their loved one when they're dying. And this has been a major problem that we've dealt with. So we should think about the fact that wearing masks is the other way besides vaccines to stop it. As this beekeeper found out, I told him as an expert in the field, I strongly recommended wearing it, but he just kept on bringing up his rights. This is the right of an idiot. And those people who do not wear masks, whether it was in the Spanish influenza, where they solved virtually all the problems by people eventually wearing masks, or whether it's in our modern pandemic, you have to wear masks around people. It protects others more than it protects you, but that's what we want to do. For those of us who have to look after older people who can't hear as well, wearing a mask with a plastic covering so that they can lip read could be very important. Remember that if you were doing care, which I'm not doing for older people in the hospital anymore, you can't have a beard, and the mask stops basically the aerosol spread. Here we see that in 1918, we had anti-mask league lockdown protests, and they are no different from what we have today. People all over the world don't want to wear masks because they say their freedoms are being taken away from them. Basically, I sort of wonder why you wear a seatbelt in the car if you think that wearing a mask is taking your freedom away from you. The Florida sheriff, Florida being one of the states that's behaved really badly during this epidemic, bans his deputies and office people from wearing masks on a day in his county where they had records for COVID-19 deaths. Lockdown, we've talked about the loneliness, have to recognize that this occurred, and we need to try and solve the problems quickly so that we don't have to keep on having lockdowns. And remember that we can use telehealth for people to talk to people, and you can see that people have looked at other ways in which they can get closer to their relatives. Not being able to get close to your relatives when you're old and sick is not a very good situation. But overwhelmingly, wearing masks is absolutely key if we want to get rid of the pandemic. Vaccines will work, but they'll only work when we have 80 to 90% of the population vaccinated. And at the moment, we don't have 80 to 90% of the population who are agreeing to get vaccinated. So we will live with masks forever if we want to solve the problem. Okay, so now let's turn to the long COVID syndrome. And if we look at this, this is Carol Todeschini, who was an Native American, and she said, it seems like it's taken a long time for my recovery. I'm making progress and starting to walk independently with a cane, a little at a time, but I'm getting there. The post-COVID syndrome is exactly like the post-viral syndromes that we see with Epstein-Barr virus, Q fever, Ross River virus, and some seronegative viruses. You need to recognize that it's common. It can last up to 12 months. In viral illnesses, it causes acute sickness, irritability, fatigue, neurocognitive disturbances, muscular pain, and mood disturbances. When we look at long COVID, it's defined as can be called a long haul or long COVID, post-acute COVID, long-term effects of COVID or chronic COVID. It's diagnosed when the symptoms are still present 3 months after the acute event. And this number is variable depending on how many symptoms you want, but it can be present most probably in the full-blown in about 5% of people, but perhaps up to 45%. And in some people, this would be a myalgic encephalomyelitis. Just again for rehabilitation, another patient's example, I couldn't stand, I couldn't walk, I couldn't get out of bed by myself. Now I can walk, she said, I'm walking with a walker. We have to spend a lot of time helping people with COVID to basically recover, or we'd finish up that they don't recover quickly. So this is looking at the long COVID symptoms, and you'll recognize that they're very similar in many ways to the symptoms of COVID. You get confusion, you do get anorexia and dysgeusia, and it stays a long time. Fatigue, often people with long COVID have red eyes, cough, postural orthostatic tachycardia syndrome and autonomic neuropathy are not rare. Chest pain, Eduardo Rodriguez, the pitcher for the Boston team, basically had to stop playing after his COVID because he got severe chest pain and he had heart failure related to his COVID. Kidney failure is not a rare after COVID. You get myalgia, you get falls, and basically the answer is it's a long road to recovery in COVID patients, symptoms lasting at least for 2 to 4 weeks in everybody and maybe longer. This is a Facebook survey done by the Indiana University School of Medicine, and what you see here is they say that almost everybody had fatigue, muscle or body aches, shortness of breath, and headache after they'd had COVID. And you can see continuing multiple different symptoms that seem to overrun. This was published today, and I picked it up this morning, and I thought I'd put it in. These are the long-term effects of COVID after 4 weeks, which is hardly COVID syndrome, long COVID syndrome, and fatigue, headache, attention disorder, anosmia, memory loss, hair loss, sweating, ageusia, hearing loss or tinnitus, nausea, dyspnea, cough, polypnea, chest pain, joint pain, and all these other things are part of what you get in COVID. And if you have COVID between 14 to 110 days, you will have still an abnormal chest X-ray or CT, elevated D-dimer, elevated pro-BNP, elevated C-reactive protein, elevated serum ferritin, elevated procalcitonin, and elevated IL-6. And here we're looking at showing other things that are important. One of these is the lowering of the hemoglobin. You also find a low albumin in these patients related to the effects, and ESR is elevated in many of the patients. So what are the major effects we see? Well, the cardiopulmonary effects, people with COVID often get clots and they get pulmonary embolus. If you think they have, you need to do a D-dimer, but you need to follow up afterwards to see if they've still got an elevated D-dimer. And if they can, the VQ scan is better than the CT because these are always peripheral pulmonary emboli. And then the myocarditis that I talked about in the baseball player, you want to avoid NSAIDs and QTC prolonging drugs in people because the myocarditis is not rare and you need to be aware, and they come along with arrhythmias as well. Post-inflammatory lung disease, need to do lung function tests at about 4 weeks on most probably everybody following COVID. Breathlessness is very common, and breathing exercises and home pulse oximetry need to be done. If the person is coughing and getting short of breath, you need to do a methacholine challenge because they have an asthma variant. And pulmonary rehabilitation is absolutely key, and you will find that you will decrease the 6-minute walk time in about 93% of people versus only about 80% of people if you don't do the pulmonary rehab. Anosmia and inability to taste are very common. And basically, you need to do stimulation therapy. This works fairly well post-infectious in post-infectious patients. You use rose, eucalyptus, clover, lemon. You do twice daily training with the 4 odorants for about 16 weeks, and you can get a significant increase in olfaction in about 2/3 of the people. It does much better post-infectious than it does in post-traumatic people. When you look at the other things that happen, fatigue is very common. Most people with COVID lose muscle mass, whether they have cachexia or not. And you can use the SARC-F test to pick up whether they've got sarcopenia. And if they have, they need to go into an exercise program. You need to look for weight loss, and you need to treat weight loss if it's present. Dysphoria and depression, you use the PHQ-9 to recognize these and treat. Psychological therapy will work for many of them. Anxiety, the trauma syndrome. Watch out and exclude sleep apnea in people who have fatigue. It's one of the most common causes of fatigue. About 10% of people before COVID, and this has gone up fairly dramatically following COVID. And then physical frailty also will produce fatigue. Remember, muscles talk to the brain, and they tell the brain, I can't work well, and that's how you get fatigue. How do you treat fatigue? You use graded exercise. Now, when I put this out on my Twitter feed, somebody, I won't say which discipline, wrote a scathing Twitter telling me I was an idiot, that you can't do graded exercise in people post-COVID, because if they have POTS syndrome, basically they're going to get tachycardia and run into trouble, and some of them will develop severe exercise. Notice the word graded. Graded means you work out what's going on with the patient and you increase the exercise a little bit at a time. You don't say, I'm not going to do exercise because you feel lousy. In that case, most of us would never start an exercise program. So recognize you have to go slow. You have to monitor people. You need a pulse ox early on to see how they're doing. People who've got fatigue should get leucine-enriched amino acids to try and build their muscle back. They need support and psychological therapy. Psychiatrists should see them if their PHQ-9 is greater than 15, and the nocturnal pulse ox should be done. And if it's positive, you should think of sleep apnea and treat with CPAP. Brain fog, you need to screen people post-COVID for changes in their mental status. We use the St. Louis University mental status exam. It's the only one you don't have to pay for, the only mental status exam you don't pay for. So if anything else you do, someone will come and go through the records, and they will come back and ask you why you haven't paid. The Montreal Cognitive Assessment expects you to get paid for training, and then you don't have to pay afterwards. But they are, by the way, these two also pick up mild cognitive impairment. Things like the mini mental status exam do not do that. We've developed out of the slums a rapid cognitive screen, which can be done in about 2 to 3 minutes, which works about as well as the slums. If they are positive, if they've got mild cognitive impairment or worse, you want to do brain stimulation games, cognitive stimulation therapy out of the University College of London. It's done up in Kirksville. So Deborah Bessing runs the program up there. Many of the students have been involved in it. Is a great, great way to improve people who've got early cognitive dysfunction. And if you add it to exercise, it's even a better way. And then you need to exclude depression and sleep apnea in these patients. So just to summarize and look at the pathophysiology of long COVID, basically, most of the pathophysiology is due to the marked increase in pro-inflammatory cytokines, which will cause muscle loss and cachexia, leading to fatigue, which will directly affect the brain, causing microglial activation and cognitive impairment, and will cause fibrosis and a decrease in cardiac function. In addition, blood clots can affect the brain and also the heart. And then the chest pain, dyspnea, autonomic dysfunction is related predominantly to the changes in the ACE2 receptor and the changes then in angiotensin and down, leading to increased vascular permeability, inflammation, and a decrease in PO2. The American Academy of Physical Medicine and Rehabilitation has said the following is what you should do post-COVID for people. Begin an individualized and structured titrated return to activity program. This is some kind of graded exercise. It's not just sit there and when you feel like it, get up and turn the TV on and off. Discuss energy conservation strategies. These are very important, particularly early on. Encourage a healthy dietary pattern and hydration. And then this is something that you need to get together all the different professionals to help. So you need your PTs, you need your OTs, you need your social workers, you need every single person, psychologists where necessary, so that we can all work together to improve the outcome for people following COVID. Here is another approach to meeting the need of long COVID, and basically it's poorly reported. A lot of studies now are showing that people don't pick it up, and if you don't pick it up, you don't basically develop and recognize that you don't develop any system for it. It's extremely important to listen, believe, and avoid stereotypes. When I treated a lot of infectious mononucleosis when I was a resident, people would ignore people with it. They do nothing for them, and they would tell them that this was all psychological. It's not psychological. Thorough clinical assessment and investigations have to be done. You need inclusive diagnostic criteria. You need personalized treatment and rehabilitation. You have to have equitable care pathways, multidisciplinary care, and employment rights and occupational health have to be discussed with the person. There's huge amount of research that needs to be done looking at the pathophysiology of long COVID. So to finish up now, basically, I just need to point out to you that long COVID is something that occurs very commonly, and we have a long way to go, both for the patients, but also for the clinicians. We have to recognize it. We have to work on developing programs that specifically look after the people with long COVID till they're highly functional again. Finally, not quite finally, but close to it, can the vaccine improve persistent improve symptoms for COVID long haulers? There is some evidence, but not great evidence, suggesting that if you have long COVID and you get a vaccine, you will improve quicker than if you don't get the vaccine. So finishing up, show you this young lady who is 107. She became a sculptor and was very famous for her sculpture. And she developed her first COVID when she was in 1918, and she had a second set of COVID when she was 105 or 6, I think. This is about as well as you can do. And so recognizing that basically you can recover from COVID. You can have COVID twice, as shown by this one lady, and the other lady was 113 when she got her COVID and recovered. So good healthcare can make a big difference. So I'd like to leave you with a positive message. The storm will pass, the sun will shine again, and most importantly, vaccines will come, and we need people to be vaccinated if we want the sun to shine again. So with that, I'll stop. And if there are questions, you can ask them. If you want to argue about anything I said, I'm most probably wrong at least a third of the time. And my politics is obviously wrong about 85% of the time. So you're welcome to argue with me. Thank you very much. Okay, are there any questions? There are 32 comments in the chat. Do I have to read them all? Please tell me no.
No, I think those are students actually signing in.
Oh, they're signing in. Oh, I feel much better. If I was going to read 32, I think I would have run away, Deborah, and I have never talked to you guys again.
Yeah.
I have a question.
Yeah.
So, what are some strategies that you would recommend for patients who are feeling lonely during this COVID epidemic?
Well, none of us have done very well because the epidemic came and we had made no approaches to doing this. And so there are lots of things that can be done. A group in England, two young exercise trainers, actually started to do tele-exercise for all the nursing homes, and they did a wonderful job for people. So you could do it in your room, watching basically on the television, so it could be done. So that was one of the things. So I think tele-exercise is very important to make available, and really did not get widely made available in the United States that I'm aware of. Hopefully, Deborah Blessing and her colleagues did better than we did down here. There are things like the Friendly Villages or Circle of Friends, which can be done on a telehealth program, and certainly having telehealth programs, connecting with people through telehealth. I think the other thing that we did very poorly is we just banned, particularly in nursing homes, but in long-term care, or told people you can't visit your relatives. And if I'm an old person and I'm stuck at home and I can't be visited, I'm going to go crazy. So we need to have testing developed early. People need to be tested regularly, and they need to go out and visit their relatives to a large extent. Now, in our nursing home, the first person who got really annoyed about being told not to be able to visit turned out a week later to have COVID. So we were very happy that he couldn't visit, but that did not encourage us to try and get many more people visiting. And I think those things are important. You've got to keep on talking to people. You've got to keep them active. And, in the long COVID, it's all the same things. You're going to work with them. You can do cognitive stimulation therapy if they're not thinking as well as they did before. This works very well. Some of you, I think, have done it, but Deborah does a wonderful job up there with the CST, and that's part of a long COVID program. Talking to people and helping them with their depression. So it's like the post-traumatic therapies that you do, and always include an exercise program. We found with the CST, if you add the exercise, your outcomes are amazing, and you can have people who were moderately demented being totally normal at the end of the year if you basically put an exercise program together with CST. So those are the things. But then the second part is to look for things that may be different. Look to see if the person's got a clot and you're not thinking about the clot. So if the D-dimer is elevated, you've got to look for the clots. You've got to look and see if their PO2 is low, what's going on with their lungs. Make sure you treat them. Look to see if they've developed an asthma variant and need treatment for that. So it's sort of working your way through all the possible conditions they should have. And I do think that basically the stimulation therapy for smell and taste is very useful for multiple reasons. It makes the person feel they're doing something. And when people lose their smell and taste, they start to stop eating, they stop everything. So those are the things, but it's a huge amount of work. And, realistically, in the United States, worse if you're an MD, but not necessarily that good if you're a DO, particularly as at least half of the DOs I know think that they should behave like MDs, which I disagree with, because I think many of the things that you guys do are much more useful. The massage and all these things can be done. And you've got to realize that putting together a group of functional people to help people and finding ways to pay for that is extremely important. We will pay for ridiculous drugs that are not going to work for Alzheimer's disease, but we won't pay for a group therapy course which does work. So you've got to explain to me why in the United States we downgrade the use of human beings. The treatment of COVID at every level, from the beginning right through to the end, requires lots of PPE and lots of people being available to work with people and making sure that you know what's going on and what the possible causes are of the different symptoms. Does that help a little bit?
Yes, that was a very thorough explanation. I really appreciate it. I also really appreciate your comments on restraints. So thank you for all of your tidbits and discussions that you gave in this lecture. I appreciate it.
Well, I'm glad you appreciated it. Thank you. Any other thoughts or questions? Looks like we're running out of questions, Deborah. You know, the one thing I have to tell you is if you don't ask questions, that means you didn't understand the lecture, you don't care about the lecture, and therefore we wasted our time lecturing to you. I've been doing this for years, and it's only when people ask questions, and particularly if you think your question is stupid, it turns out that everybody else has the same stupid question, and it's usually not stupid. Not going to work, is it?
Well, Dr. Morley, I was going to ask, you know, these folks that are like in their early 50s, you know, to mid 50s, or, you know, latter 40s to mid 50s anyway, that are, you know, that are on the vents for weeks, that end up with the trach, you know, will they experience many of the same things that older adults? Or will they have even more difficulty?
So if you, that's why I put in the post-ventilation syndrome there. That occurs at virtually every age. It's an incredible problem, particularly for strength, but to a lesser extent for people being depressed, having post-trauma syndrome as well. It doesn't matter what age you look at. You see some of this in children as well when they go on vet. I don't know much about pediatrics, but it's reported that the kids see the same sort of thing. You know, when you've been isolated and really lost 2-3 months of your life, it's incredibly hard to get you back. And that requires a lot of people talking to you. It requires a exercise program that's disciplined, that somebody's going to help you do, because you're not going to do it by yourself. And it requires making sure you're not missing something, you know, such as that their PO2 goes low at times, that they have the asthma variant and things. All of these things are extremely important. And to be honest, we don't do a very good job at this. You know, we're so much better at giving expensive drugs to people that may or may not cure them. But when it comes to doing the things that I see as why the osteopathic school was developed, you guys were developed because they looked at doctors and said, doctors are pretty stupid, you know, they don't do the things that need to be done. And if we do some of these things, we'll get a lot more people better. And obviously we need the high-tech stuff, but the low-tech is equally important. And I think we've got to keep on remembering that. And this COVID, I think, has brought that back to us in a big way. It's also true very much for people with dementia. The better than drugs are the low-tech things, and we've now got enough data to say they work much better than the drugs that we have available.
Thanks.
I had another question. So when you talk about doing the exercise therapies, is that separate from recommending physical therapy, like on discharge?
Yeah, you recommend physical therapy. Physical therapy will see you for a while, and then they will tell you that here's a set of exercises, go and do them. About 60 to 80% of people never do those exercises. So I am a great believer in exercise physiologists doing this. And I've seen wonderful results from people whose life is exercise. And you've got a program up there in Kirksville that does the exercise physiology. These people are wonderful. They care. They put the time in. They know how to get people to do things. Whereas many physical therapists are super specialized, but they're not very good at taking the person who's just like me, inherently lazy and doesn't like to exercise. And I played professional tennis, so you can't say it's because I can't exercise. It's because I'm lazy. I hate exercise. And, but when I go down to Perry County, they always put me in the exercise group. And halfway through, the exercise therapist taps me on the shoulder and says, you better go find an exercise therapist. You're much worse than the 85-year-old. And I say to them, well, I'm nearly there now, and they say, stop it. You need to go exercise. And I need somebody like that to get me to exercise. It's got to be somebody who understands and cares about getting you to exercise. I hope that makes sense. I'm not offending physical therapists. They do wonderful things. By the way, in hospital, there is no excuse for not having 2 5-minute exercise periods for every patient in hospital, and that includes the people on ventilators. We should exercise. The data suggests that this works extraordinarily well. Tremendous data out of northern Spain from Mikel Esquerdo. He used to be the coach for the Barca soccer team, the physical therapy coach, and then he became the physical coach for Liverpool, 2 of the best teams in Europe. And then his wife had a baby and said, you can't keep on traveling all around the world all the time. You have to go home. So he got a job teaching and educating people about exercise therapy. And he's done wonderful studies showing that in hospital, you need to exercise people, and it takes an exercise therapist coming by, getting you out of bed and making you do things. And that is not the norm anywhere in the United States. It should be in Kirksville, I hope. I'm going to pretend it is the norm in Kirksville, because that's what you would expect at an osteopathic college.
Do you have particular recommendations for physicians convincing other physicians that the vaccine is good for our patients?
Well, I'll try and say this carefully. So one of our physicians didn't get vaccinated until she was told she couldn't keep her job if she didn't get vaccinated. And she got vaccinated 2 days later. So first of all is money. It sounds silly, but it really is. Secondly, it's totally beyond me why a physician would not want to get vaccinated. And I know physicians who don't. So I'm not telling you it doesn't happen. I'm just saying it's beyond me. I think that the answer in my mind is to say, well, then you should not be allowed to go anywhere near a patient if you're not vaccinated at the time of COVID, because you really are committing manslaughter. If you go in and you happen to have developed COVID, you weren't vaccinated, and you walk into the room and you basically spread the stuff, but it's one of those things that flies around the room. You spread it over the patient gets it, and they die from COVID. If I went into a room and I basically beat somebody up, I would be told that I was the murderer when they died. And I don't really see much difference. I think it's trying to get through. Now, having said that, I've just finished, you saw the thing going through all the different reasons why people don't get vaccinated. And you need to basically go through and try and find the reason and work on trying to be logical. And sometimes I'm very bad at this, so I'm not the person to ask to do this. But there are nice people who will work on it and do it. I mean, I understand if somebody is African American, was brought up in the South, heard all about the horrible things that doctors did to patients, but they don't want to respond and have the things done to them and have vaccines and stuff. There is no religion that I know of that basically clearly says that God is going to not let you go to heaven if you don't get a vaccine. So religious reasons are not really there. These are fantasies. Somebody's added something to their religion that wasn't in any of the religions. So we've got to work with them, but you've got to do this in a rational way, because it's no use doing what I'm doing now and just say, well, you're just stupid if you do this, and you shouldn't be allowed to work, and you shouldn't be a health professional, all of which I believe, by the way. But that's not the way to do it. And I used to spend a lot of time in our nursing home getting large numbers of our nurses' aides to have the flu vaccine because they were a danger for the patients. And I would go and get vaccinated in the nursing home. I'd scream, I'd cry, I'd say it was horrible. I'd explain to everybody that I'm falling apart. And if I can do it and the doctor can feel this bad when he gets vaccinated, maybe you guys could. And we increased the vaccination rate from about 50 to 70% with me doing that each year. But we still didn't get the other 30% vaccinated. Okay, so you recognize it's hard. It's very difficult to understand why people think the way they think, and, we've been bombarded by physicians who've worked for politicians who I think should all have been put in jail. I mean, I have never seen a group of physicians behaving more badly about saying things, basically it makes no sense. We should all agree that you need to be vaccinated. And it's not that difficult to agree on this one. The data is overwhelmingly positive. Your chances of not dying are very high. Your chances of not spending time on a ventilator are very high. Why would you not get vaccinated? And your chances of not hurting people. And that's why we go into medicine. I can't see why anyone would go into medicine and then want to walk around trying to hurt people. It's sort of beyond me, but that's me. And I realize that I'm not helping you because everything I've said will not get somebody who is a physician basically to vaccinate. You've got to think very hard how you approach them, talk to them. Obviously, job loss is most probably the one that most will work, but it's really hard.
Any final questions or comments for Dr. Morley before we let him go? I do actually see some of my former ICST students on the call. Yay, go forth and conquer.
I just want to say that I put a new link in the chat for the participant form. If everybody could complete that before they leave, the program ID is there as well.
And please try and do the ICST if you can. It's an incredibly good way to learn what you can do by using methods that fit the osteopathic belief as opposed to the MD belief. Okay, it's all I can tell you. And there are many wonderful things about the osteopathic belief. I have spent my whole life massaging the necks of my older patients and curing them instead of basically giving them drugs to get rid of their neck pain and the stiffness. And quite honestly, I had an osteopathic physician when he was finished, came down to work with us in the fellowship, and I started to massage somebody's neck, and he was from Kirksville, and he said, "Why are you doing that?" And I said, "Aren't you an osteopathic physician? Didn't they teach you this works?" And the reality is, we've got to recognize that it's not just medicines and surgery that are the secret. A lot of it is talking to people and doing the hands-on things that make a big difference. And that's a big part of being a great doctor. Being an average doctor, who cares?
Well, Dr. Morley, I think that I haven't seen any other comments or questions come into the chat box. It's about 1:07, so we don't want to keep you any longer. Really encourage the students to finish that survey before you leave. Dr. Morley, always fun to see you. Always great to hear what you have to share. It's always informative, and hopefully I'll see you again in person.
Yeah, sometime within the next 20 years of people get vaccinated and wear masks. Okay, goodbye.
See you later.